Thank you for inviting me to speak today, and I'm sorry I can't be there in person. My name is Matt Inada-Kim. I'm an acute physician working in Hampshire Hospital's NHS Foundation Trust and the National Clinical Director for Infection Management and Antimicrobial Resistance. And I'm here today to talk to you about perhaps the time for a different model of how we address infections and the care of those with infections. If we think about the myriad of different elements of infection care, and that's everything to do with data, measurement, prevention, vaccination, the way we build our hospitals or build our healthcare environments, the conditions of interest themselves, such as cellulitis, sore throats, streptococcal infections, urine infections, and then the extremities of either treatment compared to the complications of missing serious diagnoses like sepsis. We start to build together a pattern of just what it is that we are trying to address with infection-related care. And the fact that sometimes there are different aspects of infection care that are squirreled away in different silos that don't always interact or speak to other parts of the system, trying to address infection in other ways. And that can be harmful. Bringing together problems or challenges like antimicrobial resistance, together with sepsis care, together with infection prevention and control, perhaps might be a way forward, together with intrinsic belief that actually getting our clinical pathways right is critical to actually delivering best outcomes. Pivotal to all of this is the important recognition that optimized infection care is what patients and clinicians are genuinely after, and that all these other elements enable that, but they cannot do it alone. If we think about infection itself, it's a big problem, but I don't think it's always well recognized, particularly by non-infection specialists or people not working in the field, or indeed sometimes by people in the field themselves. If we look at the top reasons why patients come into hospital as an emergency or why they're admitted, infection tops the lists of suspected diagnoses. From the emergency department perspective, and that's the SNOMED CT codes, you can see that respiratory tract infections are the #1 reason for turning up in an emergency department, closely followed by urine infections and cellulitis. These are the reasons why patients come in. And when you add up suspected bacterial infections on their own, they're around 15% of total emergency department attendances. When you look at the activity across the NHS, we've been increasing year on year for the past 20 years. But the suspected infection workload within has outstripped the increases across all other conditions and is potentially responsible for that rise. And this is sobering, but also important to recognize in terms of how we address it, how we invest in it, and how we develop teams that are able to cope with the challenges that infection management brings. This is not a well subset of patients either, the patients coming with suspected infection. As you get older, you're more likely to be admitted with infection, and that's what this SOS admission rate is, suspicion of sepsis, as we call it. And as you can see by the blue histogram, as you get older and in every single age band, there's an increase in the total number of admissions. The numbers of patients dying increase as you get older as well. And the mortality rate, which is the solid red line, increases, as one would expect as one gets older. Defining that, understanding that, and appreciating that is really important. And also appreciating that mortality rate. So if we look at those infection-related deaths across England over the past 8 or 9 years, we can see that there's nearly 500,000 in those 80 plus compared to less than 1,000 in those under 5. Quite right, low numbers in that group. The mortality rate varies from 20% in those who are older and 0.06% in those who are very, very young. These are important contextual things that we need to understand moving forward. The challenges are extreme. Right now in the NHS, we are dealing with huge numbers of patients who are complex, who have comorbidities, who are old. We're in some ways victims of our own success. The advances in chronic disease management and preventative care have led to a particularly frail and particularly vulnerable population that is surviving and that keeps getting admitted. And this is a tough group to cure, to fix, and to turn around quickly. We can see that 20 years ago, we didn't require more than 10 comorbidities as a coding strategy when looking at hospital populations. Now, we have an entirely new categorization of 50 plus comorbidities who inevitably have a very high mortality rate and who come into hospital and stay for a very long time. There is an increasing growth within the population of those who are particularly vulnerable to infections, again, in part due to our advances in chronic disease management and preventative care. And indeed, touching 4% of the population are now classified as being immunocompromised. There's more availabilities of very complex treatments that are transforming the lives of patients with inflammatory bowel disease or arthritis or cancer, but leaving them vulnerable to potential infection. This increase of success has led to massive changes in the population we see. And we must understand that to really understand what the impact is of our attempts to prevent infection, to manage it properly, and to reduce antimicrobial resistance going forward. If the numbers of patients coming in with infection are rising exponentially as they are, we need to be cognizant of that in our strategies and our measurements of those with antimicrobial resistance. Recently, we had new national sepsis guidance published by the Academy of Medical Oncologists that I have the honour of working with. NICE have recently ratified that guidance. And it hinges around two clinically driven elements. And this is why has been so well welcomed by clinicians across the country. The two variables we look at are, one, the severity of illness. And in adults, that's the NEWS score. So it's the physiology, the blood pressure, the respiratory rate, the oxygen level, the temperature, the cognitive, or the conscious level. And when you look at that, and you also, on the other hand, think about the certainty of bacterial infection, we have a sort of graph that forms with the x-axis being the severity of illness and the y-axis being the certainty of bacterial infection. And when you join these two together, you get the pattern of thinking about how sick is the patient, what's the likelihood of infection, where does my patient sit within this graph, and how will I base my decision to give antibiotics based on that position within the graph. The timing is related to the severity of illness or the acuity and the certainty of bacterial infection, which means if you're in the top right corner, so you're really sick and there's extreme certainty of the bacterial infection, you go early with antibiotics, no delay at all. But if you're in the bottom left corner of that graph, you can probably afford to wait because the risk of mortality or a really bad outcome is quite low. We need tests to be sent and we need a review with the results of those tests. There's no massive urgency. And then you have the bit in between where you have either a well patient who might have infection or a very sick patient, and there might be the possibility of infection. But again, the window of time is important to understand because actually the evidence for 1-hour antibiotics within sepsis is not strong. It's a little bit stronger in the cases of septic shock, but not so certain with just mild or moderate sepsis. What's key to this guidance is clinical judgment and use too, and appropriate, judicious, but timely use of antibiotics. So our categorization was based on severity. So mild to moderate instability or acuity, which we call a NEWS 2 score of less than 5, essentially, is not that urgency to treat unless there's significant clinician concern for other reasons. And we put people on a monitoring plan that's consistent with normal all-cause deterioration, sort of regular observations, reviews, and sending the right tests to get the diagnosis. But understanding that this on itself doesn't tip a patient into necessarily having sepsis. That changes as soon as you hit a NEWS score of 5 or more, at which point, if infection is likely, you get on and treat it. And you have essentially a 3-hour window when a patient is sitting between 5 and 6 to get the antibiotics in. 7 or more equates really to shock and really severe infection. And you have less than an hour once the diagnosis is made. It's really important to understand it's once the diagnosis is made as the starting point for when the clock starts ticking. And then the timeliness of tests, source control, and review are all based on that severity. So it's about that mix between certainty of bacterial infection against illness severity. And that was the great change that happened with that guidance. Coupled in with this idea of infection management being a global and all-encompassing element, we need to think about what happens in the community, at home, for patients with mild, moderate, or severe infections. And from a moderate and severe perspective, we have a number of ways of treating patients in their own homes with increasingly aggressive treatment, be it high-dose oral antibiotic treatment with diagnostic tests, and self-monitoring, or indeed intravenous treatment in patients' own homes or delivered in same-day emergency care facilities. There's a great deal of treatments happening out there in skin infections, urine, chest, bone, joints, or even endocarditis. And how those are managed is really important. And yet we have same-day emergency care that doesn't always talk or collaborate with outpatient antibiotic therapy with hospital-at-home strategies or infection hub strategies. How do you build all that together so everyone is working together along the same lines and there's clear communication and clear efficiency? How can we improve all of this going forward? So without a program within a locality, region, or indeed nationally that pulls infection management together, we're at risk of pulling ourselves apart, even with the relatively simple subject matter of community infection management in patients' own homes. The prize of getting this right can be considerable, both for elective recovery or non-elective recovery in terms of the impact on length of stay, hospital admissions, outcomes for patients, quality of life, independent recovery. Coupled with this, we also have the advent of diagnostic tests, again, excitingly more and more in the community. Three main buckets of tests, in my opinion. One, a test to define whether a patient has an infection or it doesn't have an infection. Two, identifying the bug itself. Is this a bacteria, a virus? What is the name on it? And three, how severe is this illness? This is a patient that is likely to have a bad outcome, potentially die, or is this a patient who's going to do really well and is actually relatively well? And if we can hone our testing, our point of care testing, to a 15-minute rapid point of care test that will tell you if a patient has an infection, if it's antibiotic amenable, and if it is really mild or severe, I think it would really assist decision making in the community, which is sometimes the trickiest place to make those snapshot decisions. And there is stuff in the pipeline moving towards that, but we haven't got to the promised land just yet. Exciting stuff. What this joined up approach also enables is for us to really think about the systems themselves. How might we redesign our healthcare system to actually meet the need of our patients? Thinking about, again, buckets of where there is tension across the system: primary care, urgent care, emergency departments, ambulances, the workforce, and actually keeping people working in the NHS sustainably, and then the inequalities and deprivation as being four kind of points on the compass. Actually, our solutions to address all of them within the infection world will have massive ramifications because of how common infections are and how prevalent and how important their management is. When we look at the urgent side of things, we can start to think that within respiratory infections themselves, there's a massive amount that turns up potentially in the wrong part of the system, i.e. in the emergency department instead of in the community. And that's not to blame primary care, because they simply don't have the capacity sometimes to actually swallow the workload. And patients are worried. Sometimes they go straight to the emergency department. Studies have proven this, both in terms of the sheer weight of numbers, but also the potential impact of providing a greater community solution for assessing patients in the community instead of a hospital when they present with acute infections. We know there are disparities of outcomes across different geographies, something we need to address. But to address that, we need to know, we need to measure appropriately across the country and in our regions using the same ruler. We need to better understand the impact of deprivation and why it is we have such a shift in outcomes between the affluent and deprived areas. And there is an element of environmental, and there's certainly an element of preventative or chronic disease management, but there's also a degree of and an element of how reliably you can access community healthcare when you are in crisis and whether there's a delay. And this influences the severity of illness we see within emergency departments. And I've worked in many places that are both deprived and many places that are affluent, and the two cohorts of populations that you see at the front door in those environments are radically different. A recent venture has been to think about how we might better manage acute respiratory infections, prompted really following on the coattails of COVID. We had a Group A strep pandemic, that you'll recall, in 2022 winter and 23, that led to a massive surge of respiratory infections, nearly 350%. And the country asking, can we do things differently? Do all these patients really need to be in an emergency department? Do they need to be in the traditional general practice model, or could they be seen in an alternate location? So a number of hubs were set up to deal with this challenge using these core principles, providing urgent assessment within the community, an ability to diagnose, treat, to monitor patients and provide care provision in the home, join up the pathway. The idea of improving access for patients, particularly in areas of deprivation, was key. It also acted as a focal point for prevention, thinking about reducing nosocomial infections, but also providing optimal care again in the community. You shouldn't have a patient coughing and spluttering with infection-type symptoms next to a patient on immunosuppression with cancer who's elderly. It doesn't make sense. And, our model has to reflect the risks to the population. It also allowed us to delve deeper to actually develop a more optimal infection approach, thinking about better stewardship, use of point-of-care diagnostic tests, the use of same-day services to coordinate care in the community using what we call a single point of access, a single communication point to improve the efficiency with which patients are processed, because it can be a really chaotic environment. And this in itself was logical and probably led to a reduction in activity elsewhere in the system. Thinking about that model of how a patient gets sick, what they notice when they're sick, and how they enter the healthcare system is really important. And then aside from the clinical management elements of triage, assessment, diagnosis, treatment, the monitoring, the recovery phase, we have some really big themes that we can address within this sort of community-driven approach, thinking about infection prevention, antimicrobial resistance, data and capturing real-time data, and the training of our healthcare professionals, an integrated care workforce working in a multidisciplinary manner to actually manage patients in their own neighborhoods or places. So this kind of holy trinity of thinking about prevention, management, and resistance all together, I think is the way we're going to crack things. These hubs were pretty successful. 363 were set up, seeing around 730,000 patients. When you ask the patients what they would have done otherwise, half of them would have turned up in the emergency department, half would have sought a GP appointment. They're cheaper than the traditional model of going to an emergency department, and we covered around 90% of the country. Healthcare professionals thought that it really made an impact, and so did patients who loved this ability to actually come and be seen same day. And it remains to be seen, because now the funding is divested to the regions. It's up to ICBs to invest in them. Now, clearly, you probably don't need one all year round, but come winter, there's probably a growing call for these, if you look at the numbers and the swings. This concept of thinking about things together is really important. Within the urgent care world, there's a lot of talk about single point of access, as we've discussed, the use of same-day emergency care facilities within hospitals, the use of assessment hubs, urgent community response, and telemedicine, as well as pharmacy assessments as well. We've got to build a picture as to how all these work together. And then you'll all know about virtual wards as well, and the ability to deliver hospital-level treatments in patients' own homes. These are all interrelated things that need to be brought together in a manner that gives you overall control over infection management within your locality, your ICB, your region, and nationally. And each one of these touch points the patient encounters is an opportunity to further educate, empower, optimize chronic disease management, prevention opportunities. And it's building that awareness across the system that I think will have massive implications and improvements. So if we think about sick patients everywhere, infection is a very, very large part of it in terms of the emergency workload, both in hospitals, but also in the community, addressing all major systems, syndromic type presentations of these. And if we're really serious about cracking this, we've got to think about infection management along those lines of what the diagnostics are, the prevention elements, the treatment, resistance, sepsis within there, data and measurement, improvement, how we communicate and influence behavior of patients and how they think, and also doctors and how they think, underpinned by really good training. Because we need to better understand the behavior of patients, why they present, how they present, as well as doctors as to why we give just-in-case antibiotic treatment sometimes, and what we can do to support that really difficult decision-making. And it can be really, really tough when you've got no ability to look and find a test that will tell you the answer. And most importantly, we need to unify our strategy. And that doesn't just go for local or regions, but also nationally. We need to be pulling in the same direction at Department of Health, in the House of Commons and Parliament, and also at NHS England. A unified, aligned strategy that fits the need of patients and clinicians, as well as the managerial aims within our environments. Because this idea of optimal care, I think, will resonate much better with public and clinicians than different silo-based approaches. Getting that balanced approach of infection management will have better effect. And there are already regions that have taken this challenge on. The Northwest, with their Infection Management Board, is a good example. It's getting towards that idea of bringing in key elements together in order to meet the challenge and the need. Because all of these elements of infection management are linked. They're totally codependent. And unless we actually come together within our localities, ICBs and regions, we are not going to get there. Because improving the management of infections will not only deliver best outcomes for patients and the system, but it will save money and improve flow across the system as well. Bringing clinicians, experts in prevention, infection control, data, training, and antimicrobial stewardship, clinical pathways, and antimicrobial resistance together under one umbrella that will aim to improve the way we manage infections now and for future generations. Thank you very much.